Welcome and thank you for joining us. In this clinical spotlight, we'll be exploring Therium's Aristotle test, which is our flagship health assessment that applies systems biology and advanced metabolomics to deliver personalized data-driven insights into an individual's metabolic health. This interview is part of our ongoing effort to equip clinicians with a deeper understanding of how the Aristotle test can be integrated into everyday practice, whether for chronic disease prevention, optimization of patient recovery, or precision wellness strategies. Today, we'll be joined by a leading expert to discuss the clinical value of the Aristotle test, its unique biomarker architecture, and how its multidimensional data can guide real-world therapeutic decisions. So let's dive in. It's a true privilege today to be joined by Dr. Robert Talac, a distinguished physician scientist whose career exemplifies the seamless integration of surgical excellence with regenerative innovation. Dr. Talac is a fellowship-trained orthopedic spine surgeon with over 2 decades of clinical and research experience, spanning the Mayo Clinic, Cleveland Clinic, UC San Diego, and currently Renaxis Regenerative Orthopedic Center in Houston, Texas. What sets Dr. Talac apart is not just his mastery of minimally invasive spine surgery, but his pioneering work in regenerative orthopedics. His clinical philosophy centers on in situ regeneration, or harnessing the body's intrinsic healing potential through natural biomaterials like platelet-rich fibrin and exosomes. Dr. Talac also brings an impressive scientific pedigree, serving as Chief Medical Officer here at Therium, holding both an MD and PhD in biophysics. His research contributions in tissue engineering, cancer immunology, and spinal surgery have been published extensively in peer-reviewed journals and influential book chapters. He has led clinical programs recognized for their cutting-edge techniques and patient-centered design, building programs from the ground up, including a spinal surgery program at West Tennessee Neurosciences and an outpatient spine institute in Texas and Houston. As we dive into the clinical dimensions of the Aristotle test, I think Dr. Talac's dual perspective, bridging molecular insight and surgical pragmatism, offers a uniquely valuable lens. His experience with both traditional and surgical interventions in next-generation biologics makes him an ideal voice to explore how systems-level diagnostics, like the Aristotle test, could shift paradigms in orthopedics, spine care, and regenerative therapies. So, Dr. Talac, we're honored to have you here today.
Thank you very much, Manis. Yeah, I might be a little bit atypical surgeon because I almost through my entire career, I was kind of going back and forth between lab and clinic, and I have spent more than 2 decades on biologic treatments, whether it started with more on a cancer and of course orthopedics and regeneration. Now, mostly last 6 years, I would say I am exclusively focused on regenerative orthopedics. I have to say that I am amazed because these regenerative therapies basically cut 80% of my surgical cases. The people do not need to this, but it requires completely different approach to medicine, not mechanically looking at age, size, and stuff. We need to look really under the hood because biologic therapy is fundamentally different approach than symptom related or surgery when we just simply cut stuff out and try to screw it together or patch it, etc. So
Sure.
if it's okay, I will share with clinicians how I do the illustrative case. That's the case is relatively straightforward, so there's nothing scientific about knee pain, but I think that how we approach it, it's bring the new level. So if it's okay, without any further ado, let's jump into it.
Please do.
I have prepared like 10 slides just to go through some of the kind of case presentation, and then I will, in a second part, show you the process because I believe that that's one of the thing is the time, how you implement, because I'm a firm believer that implementation, not ideas, are the key to success. I focus to using the advanced metabolomics in regenerative orthopedics. First, let me start that this is my philosophy of my practice. There are 3 domains that need to be addressed, so you have a desired outcome. Number 1, the patient needs to be optimized. and that means different things to different clinicians. We have to obviously diagnose the injury or the problem because without knowing what we're treating, it's very difficult to implement any meaningful plan. And of course, we have to, especially in orthopedics or surgical specialties, we have to figure out treatment plan that minimize collateral trauma. As you know, us orthopedists, we sometimes make more mess with the soft tissues and healthy tissues than we fix, creating another problem when we fix one. But so I will focus mostly on this patient part today, but I will a little bit show you about these other parts. But I want people to understand that this is how I conceptually see this patient. So this patient that we are going to talk about is 60-year-old female. She had a prolonged bilateral knee pain. This is probably one of the most common problems seen in orthopedics. She also had she broke her right foot, which probably contributed to her knee problem as she had to walk or favor one foot from another. She is relatively healthy. She suffered from Hashimoto disease. Otherwise, she is the regular uh, mid-age female living in the United States. She's non-smoker, occasionally have a drink or so, a glass of wine. So no, nothing major in terms of her history. In her exam, again, she walks with a little bit antalgic gait because she has the pain in her knees. Her knees are really the physical exam is non-significant, mild tenderness over joint line bilaterally, but her ligaments are stable. She has well-healed scar after previous open reduction and internal fixation on the right foot. So again, from the perspective of orthopedic exam, a very typical patient. Here are her x-rays. Just for those who are interested, we will see that here on the medial side of right knee and also left knee, she has some narrowing of joint space. So we would call this a Kellgren KL2 grade 2 osteoarthritis, mild to moderate. So she doesn't need to have a surgery, but she's very concerned because this is affecting her quality of life. Here you can see she had a pretty nice orthopedic treatment on her right foot, with 5 screws and of course a pretty extensive scar. But she came to me because her orthopedist was injecting her knee with steroids and she didn't feel that this is a long-term solution. So she wanna avoid surgery. So she would seek the regenerative treatment. Again, very typically, this is a 60-year-old female with a grade 2 osteoarthritis. Just for those who are not orthopedists, this is a Kellgren-Lawrence classification. But the plan is a different. Traditional orthopedists was very likely offer this lady modification of activities, steroid injection or so. And then if the knee would not change, they would probably offer her a surgical intervention or total knee replacement. I specialized in regenerative orthopedics using a platelet rich fibrin, which is blood derived biomatrix. And therefore, to me, to make the treatment successful, I need to look at biological parameters. And one of the major problem in patient in US is the metabolic syndrome and specifically chronic inflammation, because that may contribute to arthritis and also it may fight my treatments, because ultimately what I do, I manipulate patient immune system to fake the body to use the natural healing processes to revert this osteoarthritic process. So the number one treatment for this is to do Aristotle test in me to look at metabolic parameters. And also, we would like to look beyond just knee, because the patient ultimately coming to me to become healthier when she leaves my office. So the plan was to do our Aristotle test. I would inject what we call extended PRF biomatrix combined with some collagen rehab program. And then she will also get customized nutritional lifestyle plan, and I will show this to you.
And
Uh,
Robert, what would be, I mean, and you, I think you touched on it um, very tangentially when you mentioned the total knee replacement, but what would be the standard of care in this instance if she went to a non-regenerative orthopedic surgeon?
Standard care for these people would be non-surgical treatment, meaning steroid injection. The
Hmm.
problem, steroid injection with local anesthetics, she already has
She always
the
had that. Yeah, her doctor
you
was
would
giving
have
her that.
that, but the orthopedist will basically repeat it. We unfortunately don't have a whole lot of other things. We would
Hmm.
just, the problem with steroid injection is that right now we know that number one, they kill the pain, but the local anesthetic and steroid are chondrotoxic. So actually, the underlying problem with the cartilage would get
It's
worse.
worsening. Yeah.
Yes.
Yeah.
So that's a kind of hidden secret. And we would basically manage this patient until she will get frustrated with a lack of progress because and would very likely agree to have a total knee replacement, which is a
Mm.
surgery that is about 6 weeks, really heavy recovery, big incision, and probably 3 months. And the problem with that is not that it doesn't work. It does work, at least on the long to midterm. The problem is that she is very young. If those total knee prostheses will last about 15 years at the best. So by 75,
75, she'll need
you
a
would need
replacement.
another. And very likely this lady is healthy. And if we optimize her health, she will live into her 80s or even longer. So she is now looking at prospect not having one, but
But two,
probably two times
two, or maybe
two
more.
times
Yeah.
the surgery on the both knees. So we're talking about four surgeries. I guess it's not bad for orthopedic business, but patients are not really keen to
Right.
get cut if they don't have to. And
Yeah.
that's why we do have a data now that regenerative orthopedics will revert this, what we almost feel like a fate. We can revert the osteoarthritis and avoid surgery in majority of patients.
Sure.
Similar like dentist would check on you every year to see whether your teeth are okay. Unfortunately, orthopedists don't do that. We don't do any preventive things. We just wait until things get to end stage. And basically, we have three options. Number one, activity modification. I'm talking about standard orthopedic treatment. Activity modification with some non-steroidals, pain medicine, steroid injections, local anesthetics as a second way. Sometimes there is something which is called viscous supplementation with also these are anti-inflammatory injections, but you have to fail steroid injections and then it's surgery. So but there is the third option, and that's this PRF that is the second generation. You may have heard PRP, that was the
Hmm.
platelet-rich plasma
Plasma. Now it's
cells. That's the first
fibrin.
generation. PRF has been the second, and this extended one is a third generation. The difference is that when you inject PRP in a knee, they will release all the growth factors within 1 hour and PRF will provide sustained delivery of biologics over 6 to 10 weeks. And therefore, only one injection is necessary. So, to get the same therapeutic effect compared to PRP, which is the older version, you would have to get 6 PRP injection to have an effect of one PRF. So
Wow.
I use those, and
Hmm.
it does work really really well. And
Excellent.
collagen is just providing a building blocks because we want to build a new tissue, and
Right. New
collagen
connective
is
tissue.
a
Yeah.
building block for that. It needs to be hydrolyzed because we
For
need to
absorption.
absorb it,
Yeah.
obviously, and because musculoskeletal tissue respond to tension, so we need to provide a rehab program that would provide the tension, which will stimulate mechanobiology and TGF beta most specifically, so the new tissue is laid and incorporated where you want it. And of course, this all is good and dandy, but if you also, the patient wants to live while we have all the information for Aristotle, I also add a customized nutrition and lifestyle plan, and I will show you this in a second. here is Therium profile. What I was happy as the orthopedist at the beginning, that her inflammatory and mitochondria profile is very good. If I would have normative, I still would accept it. So if it's yellow or orange in inflammation or mitochondria, it's very good. If it's poor, that would mean that I need to postpone my regenerative intervention until I will fix or optimize the environment, because the patient will not fare well if they, let's say, have a high chronic inflammation, advanced metabolic syndrome, diabetes, and many things that we see stem from kind of unoptimized human metabolism. Mostly in my case, I care about mitochondria and chronic inflammation, because I am manipulating a local immune system to provide healing. Okay,
Right. So it
so
seems like your mitochondrial pathways are doing excellent.
mitochondria,
They're
correct,
optimized, and their inflammatory pathways are
correct.
relatively diminished here. So that's good. No chronic acute inflammation, immunometabolism looks like it's doing well. And her overall score looks to be pretty high as well.
Correct.
She's approaching optimized. Yeah.
Yes. So she is good, but obviously now when I show these people this, there is what I call, I tell them, you are here on the left side, you are injured. We want to get you to normal, and if you really want to, we can optimize you, because normal we consider a person without disease, but it's not what we could be as an optimal. And obviously, you and I, we know both that now I chase the things that are not visible, because many physicians like myself has been treating patients only when they have a clinical symptoms, but we all know that there are processes brewing, or I call it transitional period,
Yeah,
when you go
absolutely.
from the normal well health into the disease status. And then transitional period is very well depicted in your in Aristotle test, and we can do something about these problems before they become symptomatic problems, like
Absolutely.
diabetes or cancer or Alzheimer and stuff. So for orthopedics, I look at these few domains, but I am, because the test provide me others and it's all interrelated, I offer this to patient beyond just knees. I look at the beyond my immediate source. So I, for sake of this, we will go through this just in a second. This was relatively healthy patient, and these are really key domains. So I could almost immediately proceed with a injection. Okay. So
And now we've switched the gut health domain to bone health, which I'm sure has lots of applicability
absolutely.
and relevance for you. And of course, one of those subdomains which you had a hand in building the predictive model for. So um,
Absolutely. I will show you in a second. I will show you that I work this part become like a first third of my practice.
mm,
Literally, when I see the patient, and I'll show you in a second. So, this is like my first optimization. Yes, let's fix the problem the patient came with. So, this is the extended PRF. We take peripheral blood, centrifuge it down, and then if you see, here is the how I mix in right hand. This is concentrated supraconcentrate of platelets. This is denatured albumin. It's made of the plasma. I mix it together and create this biomatrix that is protecting, that albumin will protect the cells from dissolving, and
mhm.
this will provide sustained release. So this is the all made in a clinic. It's 100% patient, no additives, no
100% patient derived.
absolutely.
Yeah,
There
beautiful.
is absolutely no additives. No, believe it or not, this technology has been initially designed for cosmetics, but because obviously women wants to be beautiful and some men now, but we
Wrinkle
use this
reduction.
for for orthopedics. So I love PRF because it almost exactly mimic natural healing environment of human body. So, and it's a great natural biomaterial, so I can add stuff and I can use it for spine to fix the crack in a disc, etc., etc. So
Oh,
again, I don't want to digress off, but we use this natural healing, and for sake of this presentation, I am manipulating local environment because when I inject supraconcentrate of platelets into the target tissue, that basically will activate a healing process because the body will think there was an injury. There is no physiological
wow.
process how blood will get outside of capillaries. And when you have a bleeding, that will initiate start the process.
Wow.
Once this is done, I will come. I create this nutritional lifestyle plan. Of course, here is the outcome of this lady.
Wow, complete resolution of knee pain.
Complete resolution knee pain.
And she's walking 3 to 4 miles a day.
She walked 3, 4 miles a day, feel more energy. Next test, 6 months, we will do Aristotle and adjust the lifestyle. Now, I have turned this to patient to I become her wellness coach.
It's participatory, right? So when we talk about the future of
Absolutely.
medicine, it should be P4 medicine, predictive, preventive, personalized, and participatory. And what you've done here is take our AI recommendations from digital twinning and 1.3 million simulations going into this protocol, and you've molded it and crafted it into your official medical document that is again in consideration of all of the personal factors of this patient. And that's amazing. Complete resolution of knee pain. You've controlled systemic, inflammation, and even localized inflammatory milieu, I'm sure, is addressed.
Absolutely. Now, my next challenge with her is to get her off her Hashimoto medicines
Yeah,
because I truly believe that we can optimize her metabolic the environment, and
yeah.
this autoimmune disease will disappear. I
Most likely, yes. We've seen that, Robert, with some of our patients, who come in either with other physicians or they're, direct to consumer patients. And we are able to get them off synthetic thyroid by, enhancing T3, T4 conversions. And once you
absolutely.
create that stable metabolic flux, the need for supplementation or drug therapy can be completely removed.
And I will tell you another secret. I two secrets. Number one, I myself have lost 120 pounds in 18, now 24 pounds, 24 months. I don't take any Manjaro and other
Wegovy,
medicine
nothing. Yeah.
that stuff. And I also have adopted this that I tell my patients that if she meets, of course, unfortunately, this is not covered by insurance. One of the problem with because insurance does not pay for preventing something from happening. That's one of the challenge, how to align incentives.
Yep.
But I am somewhat unorthodox, so she paid for my expertise and injection, and it was certain cost. But I told her that if she meets certain metabolic milestones, I will return 10% of her money.
So now they're invested in their own outcomes. I love it.
Now they need to, I am now pulling them to motivating them to invest in their body. It is very likely that it'll be successful because I just literally a transform people.
Yeah. Yeah, and that's really a shame that the current insurance model doesn't reimburse for any sort of preventive care, even though there are studies that are very compelling that show that preventative care saves, the payer systems, whether it's a single payer system, like they have in Europe, or if it's a multiple insurance company competitive system like we have here in the States. It still reduces total healthcare costs and burden, right? You have three things that really impact health. You have lifestyle factors that account for about 60% of your health outcome. You have genetic factors that account for roughly 30% of health outcomes. And then you have the 10% that's accounted for by healthcare, the quality and type of medicine you receive. But that 10% gobbles up virtually all healthcare dollars spent in this country.
Yes,
And there is no, I mean, I personally think that by 2040, this style of systems level care will become the norm, but we still have 15 years to get there. And it's going to be a very hard 15 years. And we're going to look back and say, yeah, much to our collective chagrin,
I
we did
believe
not value preventive
100%.
care.
In fact, we both know that the Aristotle has also some advanced parts like the disease signatures and stuff that are in development. And I think that that will become even more important because the doctor of the future who will let the patient develop symptoms will be considered negligent at the best
Absolutely.
because we know
Absolutely.
that there is from the system biology, we know that we are healthy. We have transition period, and then we have a disease state.
Mhm.
We know that in transition period, we have a lot of metabolites, biomarkers. They are pretty predictively telling us that this
Absolutely.
patient is on a downward path and we could intervene. But unfortunately, we rely on imaging studies and physical symptoms when the symptoms occur,
Yeah.
which biologically is way before because our body tried to compensate at the beginning. But when the all compensatory mechanism are exhausted, we develop disease. So we
Absolutely.
start in, it's almost, and I hate to say it's almost like when we start treating COVID, letting everybody be home until you become a hypoxic and then run to IC.
Right, exactly. Yeah,
Uh,
and the
that
ICU and get a ventilator. And the
correct.
problem is that right now we're still operating on, our current healthcare system is built for infectious disease. But the
Yes,
things that we're struggling with, right? Metabolic syndrome is not just, it's a cluster of symptoms, but it
I
leads
know.
to type 2 diabetes, it leads to cancers, it leads to neurodegeneration, a heart disease. These are not infectious disorders. So the model of care that we have is fundamentally ill-equipped to deal with the heterogeneous health challenges we have that are usually a factor of genetics and environment, and their intersection and their expression is beautifully captured in metabolomics. As you know, as you mentioned, there's these
Yeah.
very
So
subtle disease signatures that we can pick up and pathways that we can follow and intervene to sort of rescue a person who may be in a health to disease transition.
yeah, the point is that because I'm somewhat atypical. I am talking to researchers and I like to dig into papers and methodology and sometimes I can help myself. I'm sarcastic, but the major problem is that we cannot do research because we want to be famous and I have a PhD and I will have a this much impact factor. This is what it we can bring to the bedside or the patient. And I believe that this demonstrate is how this improve my day by day practice. I also will dare to say it's cheaper than anything else because I would have to order few MRI and other tests. MRI is at least 15 to 100 to $2,000 for both knees and to figure out what is going on. After several of those injections that she has done, which it also costs some money and for a patient, probably at least $600 for injection per injection, and you will get this at least like 3 months recovery. And but it doesn't really fix anything. We are really making the whole thing much worse. And so
But you've established a very nice apparatus of additional tests and images to do that make the hospital administration lots of money at the
yes, we
expense of the
turn the patient
insurance.
to annuity
Yeah,
because
exactly.
they keep coming and
Yeah.
they have to keep coming because we are not really curing anything. So I understand this is maybe different podcast conversation. I not I believe this is better medicine, better outcome. This will really make a difference in patient and it's comparable cost or even cheaper in total aggregate than traditional medicine. Sometimes patients ask me, "Well, I know the Therium test is not cheap like lunch money, but I also tell them, are you worried about price or the cost?" And they sometimes they would say, "I don't understand." And I would tell them, "Look, when I was younger, I would buy my younger son a cheap bicycle, but then I would have to every other day go and fix it. So total cost about 3 times more than when I would buy a reasonable bike because my older son Philip is 6'8". When he was younger, he was still a big child. So all these small toys were easily broken.
Yeah.
So I think that we need to have a really honest conversation about what is it the patient comes. My patients don't come to get shots. They want to get rid of the pain and they want to live their life. They
Yeah.
want to be healthier when they come to me. And I can only be, I call it Jiffy Lube guy, that I change the oil and don't care. And then I see that your brakes are bad. And, or I will just say, let me fix your car as best possible so you can enjoy your investment. But you have to engage the patient first. They have to be enrolled. And I force them to enroll by saying, look, this is a team game. You will tell me what you will eat. I call them every month, I call it accountability calls. They are not charged.
Very
I
involved
want them
physician.
to say, are you still on? And they're like, I am eating healthy. And I will say, I understand. No need to tell me because Aristotle will tell us in 6 months whether you did or did not.
These poor people probably
And
don't
so
look forward to
but
retesting
I'll
with
tell you,
us.
I have patients, they will come and they would say, Dr. Talac, I am not willing to follow. I have to have my 3 drinks of whiskey. I love gallon of ice cream. I went through all this. I was big. I had 4 medicines. I was having blood pressure problems, metabolic syndrome, all of it. So I understand that's their decision. We just have to be able to have an honest conversation. We lost it because traditional medicine to me is more like what is CPT code, how we can bill it, and then ching next because we have 5 minutes for the patient.
Right.
That's a fundamentally changing medicine. That's why I like Aristotle test because it replaces multiple tests. It provides more than I need to my narrow focus orthopedics. I can now provide more value to the patient and hopefully set them up. I tell them when you do this, what I'm telling you, you will know I will replace me because you will not need me, and that's the goal. In fact, on my presentation, here is the most important part. The doctor of future will give no medication, but will interest his patients in care of human frame, diet, and in a case, in cause and prevention of disease. Thomas
Thomas
Edison.
Edison. Wow. I
I,
mean,
this is my
absolutely.
motto.
Absolutely. And you touched on this earlier that, in 2040, when these sorts of assessments do become routine standard of care measures, the physician that allows disease to manifest in, a patient below the age of 65 will be reprimanded for that because and that comes with so much work that we need to do, especially in the insurance reimbursement sphere where you are rewarded for the number of patients you see, not the quality of care you deliver. But what you've said really resonates with me. Obviously, our team at Therium of scientists and professors and physicians like you who work very closely with us to develop new biomarkers, new subdomains, new health assessments. It really does make it worthwhile when you tell me, this test replaced so many other tests I would run
She
concomitantly.
is 60. 2 out of 3 white Caucasian women at her age will develop osteoporosis. It's a
Right.
humongous problem.
Absolutely.
Now, what is the standard of care? Send her for DEXA scan,
DEXA, yeah.
and we will radiate her, and that will show us only when the substantial amount of bone mass is gone.
A
Now,
density. And it's not
correct,
telling you about morphology or bone
correct.
remodeling or.
now
Yeah.
we have a whole bone metabolism panel. We can dissect whether it is a on a phosphorus and calcium problem, it is a collagen issue. I can now address this problem way before. And yes, we are working on validating whether this will replace DEXA, but at the beginning, we can now intervene way before, again, in a invisible phase
Yeah.
when we should see, but sometimes it's difficult because I would I would weigh the I would dare to say this. Out of 100 orthopedists, there is only about one orthopedist who is interested in metabolomics, advanced things, because he or she reads her literature about orthopedics and stuff. Although this is a really a fundamental thing, how you prepare the patient. So
Yeah.
future is here already, but it takes us 17 years in clinical medicine to apply what researchers already conclusively shown that it does work. Why? Because we have many things, obstacles, and one of them is a time. One of the things when I took 70 pages Therion report, Aristotle, my first question was, how am I going to spend hour and a half with the patient? Just read it. This is not a Tom Sayer novel. These are heavy information with the citations for why the test says what it is, right? But in a practice, you need to dissect it. And I found this AI tool that basically prepare the patient. I will go so far that I will not meet with the patient unless they tell me, did you have a chance to listen to the podcast, to read what I am sending to you? I am telling them I took the time to prepare, digest your information so you can have a meaningful conversation with me. If you are not willing to spend the time, this
Yeah.
will be
You got
like
to participate.
you have to
Absolutely.
participate.
Yeah, and it's really interesting that you've created this solution. As you know, we just launched for beta testing our own conversational health agent called Centaur.
Yes,
And so it's really interesting that you have worked out on your own a solution for this before we could give you software to do so. But I think it works really well. And in fact,
my
I'm
goal
going to
is
follow up on this
Centaur
platform.
probably will be better, but I just don't wait until you have somebody worked all the kinks.
Yeah,
I want to use it today. The test is available. Yes, it is not as elegant as it will be. I would love to just have a voice command to say, "Hey, give me this, give me that." But
yeah.
it also generate this, Panis. I need to start thinking, how am I communicate with a document? And yes, it is true that I work with you guys, and not to be too modest, I understand maybe a little more about metabolic pathways that general orthopedists. Not that they are smarter, but they probably forgot everything. If you are not able to ask intelligent question to AI about that 70
Yes.
pages document, it will start telling you, taurine is about this, and it cited this study. I had to go back and see, like, okay, what the study is saying, because I was just not partner to the computer.
Yeah.
But the good news is that now we need to learn prompt engineering, how you ask, what you can do, how you
How
will.
to check for mistakes because these
That's
software do
another
make
thing that
mistakes.
AI may fantasize, and I am responsible if that AI would say, you know what, this patient, based on metabolic report, you should cut her leg off because there is increased metal in her foot. It will be, of course, idiotic,
First.
but we cannot have, we have to have somebody who will be in charge of machines.
Right.
But you
Checking the
cannot be in
hallucinations.
charge if you are not understanding your tool,
Absolutely.
right? My mentor, Dr. Benzel in Cleveland Clinic, would tell me 20 years ago when I was doing fellowship with him, he says, Robert, fool with a tool is still a fool. So I keep this. It helps me. We still need to diagnose the patient. We still need to know what's going on. We need to know how the tool works. But my message to whoever will listen to this is the AI or the future is here. This is better way to figure out what's going on with your patient. It's more holistic. It's customized, individualized. This is not generic. You know how to optimize. And at the end, what I have a benefit, I have 83% of my patient after one treatment has a full recovery, complete response. 15% has two injections. These are mostly people that are really sick and I have to do more. I used to do 700 surgeries a year. I do barely 20 now.
Yeah. So you only have 2% of patients that are needing more
Well,
than
you
a
can look at
second
it
round of follow-up.
perfect. For patient perspective, I think it's great.
Yeah.
I know there are challenges. The hospital doesn't like it because revenue is 50x less.
Yeah.
But we can figure this out, and I would not change my practice. So not to be too. This is. I hope that it was not too boring.
No,
Uh,
this was really great. I think we covered everything about,
this
the
is can
patient,
be
the
any
vignette.
primary doctor who see the patient with any pain or any pain of any joint. I believe that this is relatively simple process. Yes, it will take some sophistication and understanding when the information will come from Therion team, and you can obviously ask more questions. This is very simplified version. If let's say your methylation panel is off, you need to dig deep and then you have to go after it. And but you can now ask more intelligent questions, seek more customized treatment, and ultimately results are better. So whether it's osteoporosis, whether it is what we talk about, just the garden variety of knee pain, this pain, that pain, this is about chronic diseases.
Well, Robert,
I
thank you so much for that. This has been really illuminating. Thank you for walking us through your, patient case study. We detailed what the Aristotle saw, what it recommended, and we saw that complete turnaround in your patient. And of course, we were able to obviate the need for other tests and imaging, and that is exactly the kind of use case and testimonial that we aim to receive. So that's excellent, and I hope the people that watch this do get some value out of it, even if they're not orthopedic spine surgeons. And the physicians and clinicians who are on this interview series, we are getting similar testimonies. The same sentiments and results are being echoed in different types of care
We are
practices.
now
So
maybe like pathfinders, but I think this is coming very fast. I
very
don't think
fast.
you need
It
to
is.
wait to 2040. 2040, the tools will be much more sophisticated, but uh,
Yeah.
I think that we need to change from move our target to earlier detection and
Right.
intervention
Stop treating
before
the wildfires. Look for smoke on the horizon. And even I would argue that smoke on the horizon is a little bit too
it's too
late.
late. Yes.
Yeah.
Yeah,
Yeah.
because we don't know. And
But let's get there first, because right now we're still wildfire,
yes, but this
treatment.
is my what I call my bridge tender, the mentality that I want to bring it from research to clinic and show how the practically you can use the tool.
Yeah.
We can talk, hey, how we go to this conference and have 17 papers, and for sure there will be 300 PhDs and researchers discussing whether really preheating and pre-preparing a mass spectrometer is better than this. This is a meaningful conversation, but that's a 10 years ahead of practice. But when the lady comes with a bad knee, she wants to use it, be
Right
benefited
now.
from the
Yeah.
technology now, not 20 years from now, because she would very likely already have a total knee, which is irreversible decision.
Yeah, absolutely. Absolutely.
So
And with people like you, of course, having an MD, PhD, you are the natural sort of type of person to translate this from bench to bedside. And we are always so indebted to you and thankful for your involvement on our team. So
thank you.
Robert, thanks again. And I will go ahead and end our recording.
Perfect.